Okay, so welcome everyone. We're so grateful you're here. For those of you who I haven't met, my name is Max Cates. I'm the clinical lead and director of the bladder cancer program at the Brady Urological Institute and here at the GBCI, Greenberg Bladder Cancer Institute. Dr. McConkey, who leads our institute, is making his way back to Japan today for a meeting. And so I'm happy to welcome you and host for today. Before we introduce today's session, you can find our updated programming and a new newsletter on the website. Just Google Greenberg Bladder Cancer Institute and you'll get right to it. Thanks to Stephanie Cooper Greenberg. We have a recent newsletter full of novel news to share with you from the Institute. For next month's session, Dr. McConkey will be joining us. Looking forward to spending some time with all of you around the evolving advancements in what's called liquid biopsies. As you may be reading, this notion of liquid biopsies is a non-invasive diagnostic method that allows the detection of cancer related biomarkers such as circulating tumor cells, cell-free DNA. And these are in many different types of bodily fluids like blood or urine. In bladder cancer, liquid biopsy can be used to detect the presence of cancer cells or DNA shed from tumors. And the use of liquid biopsy in bladder cancer is still relatively new. And our group is leading this work to determine the clinical utility and the accuracy of liquid biopsies, given that it holds such a promising and valuable tool for diagnosis and monitoring of bladder cancer. So stay tuned for that. It should be a really exciting session. Additionally, I want to draw your attention to a new group of programs specifically tailored around the experience of women with bladder cancer, developed and led by Drs. Armin Smith and Jeannie Hoffman-Sensis, and the program team of Pamela Goetz, Samantha Rockler, and Stephanie Cooper Greenberg. Again, all of these events are on the website, and if we can help you directly, please just email bladdercancer@jhmi.edu. So now moving on to today, I'm grateful to all of you for joining us for a conversation with myself and one of my patients, Mr. Webb Metz. We're going to have a conversation around moving on after treatments with bladder cancer, what to expect, how we do surveillance, how often and why, and patient experiences around surveillance of bladder cancer. Once again, for those of you that don't know me, I'm a urologist and urologic oncologist. I lead the Division of Urologic Oncology here at the Brady Urological Institute and currently serve as an associate professor within the School of Medicine at Johns Hopkins. So Webb, I'm so grateful for you joining us today. A little bit about Mr. Metz. He makes his home in Salisbury, Maryland. He did 4 years of service in the U.S. Air Force and is a retired NASA engineer who served 47 years at the Wallops Flight Facility, specializing in range instrumentation, which is mostly tracking radar systems. So we're going to have a discussion for a little bit, and we're going to take questions during it. Please go ahead and put your questions in as they come to you, and we will kind of go from there. I think I'd like to start the way I start a lot of these patient discussions and just kind of understand, take a step back. And I'm just curious, Webb, before you were diagnosed with bladder cancer, did you know anybody with bladder cancer? Had you heard of bladder cancer? What was your knowledge around this disease?
I was pleasantly ignorant.
Yeah, I think that's pretty common. Very few people, have an experience with it before they themselves are diagnosed. So let's go back. When did you start having symptoms? When was that, and what were your symptoms?
I believe it was May of 2021, and I guess I had the universal symptoms: frequent urinization, sometimes painful, sometimes with blood in the urine.
Okay. And then what happened next? You went to your primary care doctor or urologist. Who are you referred to?
I went to primary care. They did the urine test in the office, referred me to the urologist. I spent a long time waiting to get in to see the urologist, but eventually had a CT, urogram, cystoscopy, bladder tumor was discovered, and I had TURBT to remove the tumor, and that brings us to when I tried to get to see you.
Okay, so I see you, and what did I tell you? What was that visit like? What options did you have, and what did I tell you about your cancer?
Well, I had two hopes driving up to see you. One of the first hope was that you would dispense with you're going to lose your bladder nonsense. And the second hope was that somewhere at Johns Hopkins there would be a jar of elixir that I could drink and everything would be fine after that. Neither of those hopes were realized. And you started outlining the standard of care for bladder cancer, chemotherapy followed by surgery. And you were trying to drag me into that standard of care room, and I was holding on to the door frame. And I remember asking you about the chemo and saying if the chemo was all that it's built up to be, maybe I wouldn't need the surgery. And you told me that that was the goal, but science had not yet advanced to the goal where you could tell how effective the chemotherapy was. So I said, well, what about radiation? I've heard about that. Maybe that'll help me. And you said it's not indicated, your case, in my opinion, but I can arrange it if that's what you choose. And I really wasn't trying to choose anything. I was just trying to find out what options I had. So eventually I let go of the door frame, and you referred me to Dr. Hahn, who oversaw chemotherapy.
Yeah, let's take a pause there. A lot to unpack. So regarding the question of chemotherapy and if there's a good response, not removing the bladder. So we, along with Fox Chase in Philadelphia, had a clinical trial where basically if you had certain mutations in your tumor, what are called DNA damage repair mutations, and if you had a complete response to chemo, we would not remove the bladder and we would watch it. And that was called the RETAIN trial. And what was learned from that trial was a few things. First, the rate of tumors coming back, even when you have DNA damage repair mutations, which are thought to be associated with a complete response to chemo. And even when you have a complete response to chemo, tumor comes back 69% of the time in that study. So, and 8 of like the 24 patients, or I think, or 8, somewhere around there, over a third of the patients ultimately needed their bladder out. And many of those patients had progressed at that point, or some of those patients had progressed, had lymph node disease. So that clinical trial, that study showed us that we still need to study this, but maybe it's not really ready for prime time, that we cannot be confident that when we think somebody has a complete response to chemo, that they actually do. So we're in the process of writing actually the sort of next version of that RETAIN trial, trying to push the envelope even further and say, okay, that worked okay, but clearly not well enough. What can we do to give systemic therapy like chemotherapy and maybe immunotherapy? And in certain patients who we're confident aren't going to have recurrences, or who have all of their cancer eradicated, potentially not do a cystectomy. And we're working on that as we speak, really, this week, next week, the week after. That's something that is ongoing effort. So wanted to share that. And along those lines, this issue of who is a good candidate for chemotherapy and radiation, there's a lot that goes into that discussion. Some of it is the location of the tumor, whether it's blocking the kidney from functioning, whether somebody has a lot of urinary symptoms. If they have a lot of frequency and urgency and things like that, then hitting the bladder with radiation may not be the best thing for them. So a lot goes into that discussion as well. So let's just take that tangent, and now I'm going to keep going with you. So you go and you see Dr. Hahn. And by the way, did we talk about urinary diversions at that time, or was that a little bit later?
No, we talked about it. You told me about the ileal conduit or the neobladder.
Yeah.
And that was the choice, I think, that I was looking forward to, but it wasn't urgent at that initial meeting.
That's right. That sounds right. And just curious, did you call any patients while you were getting chemotherapy?
I did. I contacted BCAN and asked them to provide people who'd had the surgery. And I talked to 3 gentlemen, one who'd had neobladder, one who'd had ileal conduit, and one who'd had Indiana pouch. And they all gave me their opinions, and they all seemed well suited to the particular operations that they had, and they were dealing with it fine. And they told me whatever I choose, they thought I'd be okay. So that was just a reassurance, and I was happy to have that advice.
Yeah, I mean, I found, for those of you that are my patients and you're going in this process, I give my own list of phone numbers of people I've operated on who have been generous enough to provide their phone number. But Beacon is also a great resource, and will put patients in contact with other patients. Regardless, I think the act of calling other patients, it gives people reassurance in and of itself. And I wonder, it sounds like that was your experience as well.
So somewhere along the line, you've got to come to terms with the fact that cancer is real, and you got to be part of doing something about it. And those calls help to do that.
Yeah, yeah, I agree. So tell me about your experience with chemotherapy. You saw Dr. Hahn, who obviously, I work with extremely closely, share many patients. Many of the patients probably listening in, have seen both of us. But tell me about that experience for you.
I didn't enjoy it.
Surprise.
It was unpleasant, and I got through it. Everybody does, and that's basically what I did there. It really hit me hard as far as the physical aspects of it, and I didn't deal well with it mentally either. I think the bad part about it is you only go through it once, or you hope to, and if I had to do it again, I'd do a lot better, I believe. But I didn't do very well the first time.
When you say you didn't do very well, was it your physical body, or was it more psychological, mental health? Like what do you mean by that?
Yeah, the answer is yes. Both body and mind. I didn't do well either way. I got so down on the whole process that I dreaded the thought of getting in the car and going to Baltimore again and walking in the building. All the people in there were wonderful and gave me great care, but I still dreaded seeing them. And the physical part of it was something, again, I think I could deal with it much better if I had to do it again. The aspect of, I think, reassurance, I needed more. Just to tell me, I know you feel like junk right now, but you're doing fine, and the chemo is progressing. Stick with us. And I needed more of that. Needed more babying, I guess you'd call it. But
Yeah,
I
no,
got,
yeah. I think that the important point here is that, I mean, that's incredibly common. I mean, we do have resources. We have coaches, we have mental health professionals who we work very closely with. But I think it's also it should be said that it's typical to feel down at some point, especially during that initial phase of chemotherapy and leading. I would even say the hardest part. I'm curious what you found of your whole journey, but a lot of times it's kind of the few weeks before surgery. It's not typically after surgery. I'm just curious what your experience was.
the part before surgery was actually a break. I had finished chemo early, mid-December, didn't have surgery until mid-February. So I had a period of, I don't know, relief. Everything was fine. I felt great, didn't have that chemo dragging me down, and I kind of put off thought of surgery being far away. Now it's a month and a half away. I don't have to worry about it. So that was a good time as far as mental and physical.
Okay. And so now we're kind of getting into surgery. So you know, you've had your chemo, it was kind of rocky. And now you're talking, you come back, presumably. I probably did a cystoscopy and look back in the bladder. And
You did.
at this point, did we talk about you know, what did we talk about after I looked in your bladder?
I think we had a discussion before that where we
Yeah.
had narrowed down that it was going to be neobladder.
Okay.
If the look with the cystoscopy reassured you that everything would be in order for that.
Okay.
Up until that point, I had still was unsure about which surgery, and gosh, even are you really sure I need this surgery, Dr. Cates? So you've tried to reassure me and drug me in there to the surgery, and as I recall, everything went fine. But it was closer we got to surgery, the more nervous I got, and I'm sure I'm not the only one that felt that way.
No, that's very typical. And I want to go back to that to your emotional sort of changes through this time. So you chose the neobladder. So we go for surgery. Part of when I do these, by the way, just as an aside, I actually don't look at your chart. So to keep my questions fresh, I don't like leading the witness. So I actually don't know the answers to much of this. Was your post-operative course, this was about a year ago I did your surgery?
Yeah, February of 2022.
Okay. How many days were you in the hospital? Were there any complications?
4 days in the hospital. I don't believe there were any complications. Only problem I had in the hospital was getting back on solid food. It kind of, the in-between part where you go to a semi-solid diet kind of hit my stomach like a bomb. Other than that, it was fine.
Okay. And then and so we did the neobladder, you were in the hospital 4 days. And then I saw you, I presume about 3 weeks later would be typical. And did we talk about your pathology at that point?
We did.
Okay, tell me about that conversation.
Well, that was the conversation where you said that one of the sample of the lymph nodes had come back positive. So I wasn't really sure at that conversation what that meant, other than it wasn't good news. And you told me about a new drug that the FDA had approved for treatments like that. And I guess the long story short on that was, after talking to Dr. Hahn, he said people in my situation had 50-50 chance of cancer recurring. So that's where we went into you transferring me back to Dr. Hahn for further treatment.
That's right. So that was I would say that was the most jam-packed visit, that 3 weeks, because you've got stents in your kidneys draining this neobladder. We're removing a catheter. We're teaching you how to self-catheterize, which initially, and we'll get back to how your neobladder's functioning, if that's okay.
Sure.
And then we're also talking about this pathology report in which I'm telling you that there was cancer in one of the lymph nodes. So how did you, I'm just curious how you processed all of that. How did it take a while to kind of process that conversation? What was that experience like? It's a lot. That was a big visit.
Yeah, it was good and bad. The good part was I got rid of the catheter and could, go without the bag dragging around. The bad part was the news about the lymph nodes. And still I had gone through the 3 weeks, which was the low point in the recovery for me, both physically and mentally, because I didn't feel well. I was doing well. I mean, then I had a home nurse come for a couple of visits, removed the dressing, and made sure that physically I was doing what I was supposed to be doing. We learned my wife and I, how to flush Foley catheters twice a day. And thank goodness we did that, because everything worked out and I didn't have any complications because of it. Eventually, I came to grips with the possibility that 50-50 might mean 50 on the good side, as well as it could mean 50 on the bad side. So I kind of shoved it away a little bit and said, I'm not going to worry about it until I know more.
Yeah. Okay. And the drug that you were referring to that was FDA approved, I'll just take a little tangent and talk about that. So very recent, within the last 2 years, there's a drug called nivolumab, which is a immune checkpoint inhibitor. Basically, it gets your immune system to fight the cancer. And it's part of a class of drugs that includes a drug called pembrolizumab, which some of you may have heard of, Keytruda, which is FDA approved for non-muscle invasive bladder cancer. And it includes other drugs which are approved for metastatic bladder cancer. And these drugs as a class, they're the blockbuster drugs of this decade in any space. And so nivolumab was approved for patients who had at the time of cystectomy, who had muscle invasive bladder cancer that was extending into the muscle if they had chemotherapy, or into the lymph nodes, and have had really good results in terms of prolonging recurrence-free survival for those patients, basically preventing recurrences. And so that's probably the conversation you had with Dr. Hahn, and tell me about that conversation and did you decide to go on the nivolumab?
When I got to see Dr. Hahn, that was like 3 months after surgery, and I'd had a CT scan, and the bad news was there were nodules in my right lung. And so Dr. Hahn says, his opinion, that ruled out the nivolumab, and I started immunotherapy with pembrolizumab. I just completed it last week. Last week was my 14th treatment of pembrolizumab. And I'm going on. They tell me to enfortumab is the next step.
Okay.
So the pembrolizumab was effective. It's not a cure-all. I understand from conversations with Dr. Hahn that it helps 30-35% of the people. Of those people that it helps, the results are scattered. It may be complete remission, In some, it may be a slight help in others. Somewhere in the middle, I guess I was. It helped me for almost a year, 10 and a half months. It kept the nodules in my lung from growing appreciably. They've grown some, but not terribly much.
So, the topic of today, and I took a while to get there because I actually think the whole story is what's interesting. And actually, before we get there, because we're going to get to the surveillance, tell me about your neobladder functioning. Are you needing to catheterize? If so, how often? And are you getting up at night? What's that experience like living with your neobladder?
Well, that's been the success story of the whole journey. The neobladder's been doing fine. It's a learning process how you deal with it, and I'm a member of this group called the Neobladder Support Group. It's like 300 people that keep in touch via email. They have physicians and other professionals speak once a month at meetings, and they share tips on how they've dealt with neobladder. Some people have to catheterize every day. Some people don't ever do it. Some do it once in a while. It's a different, it really is, depends on a lot of things. One thing that depends on is who did the surgery. Is the surgery without problem? Did you go to the right place? Have you got the right doctor? Another thing is, did you do your part? Are you in good health other than what you came there for? Are you lucky? Did you get through it and without complications? So those things all add together. And while that group doesn't dispense medical advice, it does help with day-to-day treatment. So I'm guessing unscientifically, like 80% of the people there don't have any problems. They urinate just like they did, well, not just like they did before, but in some closely related fashion the way they did it before. Some people, like I said before, had to catheterize. I did it the first week while you evaluated whether I was voiding completely. And so after you were assured that I was voiding completely, I didn't have to catheterize anymore. I have not. So that's been almost a year now. I learned how to do it and I did it. Some people, I even learned from that discussion group that there's such a thing as mobile catheters, I guess they call them. They telescope like a foldable umbrella. So you can go in the men's room stall and take one of these out of your pocket and unfold it and use it. Never realized there was such a thing. But so some people actually have to do that. They carry a catheter wherever they go. I've been fortunate. I can urinate when I need to. When I don't need to is the problem. I have stress incontinence. If I laugh or cough or sneeze or some other things might induce it, I'll leak a little bit, but that's the extent of it. Leakage. I'm not fully continent, and I'd say like 80-85%, maybe 90%. I can do normal everyday things without a problem. Go out public, shop, or drive.
What do you do? What do you do at nighttime?
Well, that was another learning experience. Initially, I did the disposable briefs, and that's what I would wear to bed. So I ended up wearing briefs at nighttime and pads that you can insert in your briefs in the daytime. They're not as effective as the actual disposable briefs, but they're more comfortable and more regular lifestyle kind of things. So what I ended up with of doing that constantly was diaper rash. there was just too much moisture that I was holding in with these tight garments. So I got rid of that, and I learned that at night I sleep on a pad. I don't use any of the other protective devices, and I might leak once in a while, a few drops, but I get up every 2 to 3 hours
Mhm.
through the night and relieve myself and go back to bed. And I don't have any problem doing that. Some people don't. Some people think that's a burden. They don't want to have to get up so often, but I have no trouble doing that.
Yeah, yeah. That's great. Thank you for sharing that. So I want to talk to you a little bit about, what you experience in terms of, being on the nivolumab and waiting every 3 months, you're getting a scan. What's that process like of being on frequent surveillance? Did you have a routine in terms of waiting for results? And do you still? I mean, how do you manage that anxiety, and how do you manage that sort of unknown?
Well, the first scan was nerve wracking because we had no indication on how effective the pembrolizumab was, if it was effective at all. So I go to a local imaging facility here in Salisbury, and they transmit the images via uplink to Hopkins. And since after a couple of them, I started doing it myself. I would get a CD and bring it home and upload it myself, because sometimes Dr. Hahn would get the pictures, sometimes he wouldn't get the pictures. It's hard to tell where the breakdown, what end it would be, or in the middle or whatever. So I got a computer with a CD drive, so I started uploading. I can't make heads or tails out of them, but I can send them to him. And then the next morning I go back to Peninsula Imaging and I get the written report from the doctor. So that's the scary part. You sit in the car and say, okay, I'm going to open this thing and read it. Did the nodules increase in size? Did they decrease in size? And I got to the point where I could handle it, whether it was good news or bad news. Of course, good news is always easier to handle. And that written report is, as Dr. Hahn reminded me, is not always something that you can hang your hat on, because the measurements that they report, whether it be a 21 millimeter size nodule, might be that particular scan didn't take a slice of it that was at the widest point. So maybe it's a 25 millimeter. So it's not like it's an exact science, where if he has the whole slate of pictures to look at, he can make a more general and accurate evaluation of it.
Yeah, I think that's a great point. Looking out into the sort of the future, how do you think about what would be something you would want to impart to other people, sort of about your bladder cancer journey? Any words of advice, and then I'll answer some of the questions that have been propping up.
I just get the feeling that it's really a widely scattered answer as far as each patient. There's so many things that can happen, and I went along with what Dr. Hahn and you advised, and I would do it exactly the same way again. Maybe try to handle it better. I probably could have done a lot more during this time of treatment than just sitting around waiting for the next scan. But I'm retired, and I still do some part-time work, and I try to do a lot of exercising, that kind of stuff. But I think maybe more activity would have been better, and that gives you less time to dwell on negative aspects of it.
Yeah. What I always like to tell people is, the reason we're doing all this crazy stuff to you is so that you can go and live your life and do the things you want to do. So, Webb, I'll just say thank you for being such an incredible, participant and sharing your story. I think this isn't the first time I've done this. I've done this, and I'm always struck by the authenticity and the honesty of our patients, and it's really a gift that you were able to share it with us. I'm going to start answering some questions. Some of these are related. I'm going to try to stick to the ones. I'm going to start with the ones that are sort of more related to what we're talking about, but I'll answer all of them in due time. So there's a couple questions about neobladders. One just wants one question is just to explain the neobladder surgery. And then there's a couple offshoots about whether incontinence is more common in women than in men with neobladders. So, for urinary diversions, there are essentially 3 urinary diversions that are done after the bladder is removed. The main one that is incontinent or where urine just drains is called an ileal conduit. A small piece of intestine is connected, is removed, and the bowels are put back together, and then is hooked up to the kidneys on one end, and the other end is brought out to the skin to a stoma. That's called an ileal conduit. Urine drains into a collection device that is emptied once or twice, a couple times a day, and is changed once or twice a week. The kind of surgery that Webb had is called a neobladder. That's where a much larger piece of intestine, about 50 centimeters, is formulated into a sphere, kind of like a volleyball, is the way it looks. And the kidneys are hooked to one end of it, and the other end is hooked back up to the urethra. Some people are able to void or urinate spontaneously, kind of just like they did before. It's a little different because you have to bear down like you're having a bowel movement or create intra-abdominal pressure to get the urine out. But it's for some people, it's not that different. Other people, as was mentioned, need to catheterize themselves if they're unable to eliminate all of the urine. The reason that they would need to do that is because if urine does not leave the neobladder, if it kind of just sits there over time, it will get infected and people will get sick. So if you need to catheterize yourself, it's important that you do so. But that's the basic anatomy of the neobladder. The question of whether women have more incontinence than men, I'll tell you, women have higher rates of what's called hypercontinence. So because of their anatomy, it's much more common for women to need to catheterize themselves, to be in retention. Incontinence during the day is relatively uncommon. Sometimes it does happen, and there's things we can do about it, but it's relatively uncommon. As Webb said, during the nighttime, incontinence is incredibly common, and the best way to manage it is to set an alarm clock and get up in the middle of the night, or deal with the fact that there's going to be some overflow incontinence at night. So that's kind of the basic answers to those questions. Do you want to jump in on any of the things I said, Webb?
That discussion that you just had about the kinds of diversions and what complications might be, the catheterization and the being able to urinate relatively free of problems. That discussion you left out of the pre-surgery part. So I didn't know anything about that, and I think probably that was something that you meant. Let's not talk about this right now because he's already scared enough. I don't know if that was your conscious thought or not.
Well, I mean, I think it's very interesting. When you have a patient with newly diagnosed bladder cancer, there's so many things to talk about. And I usually like to let it all play out. I want people to go in with a full understanding of kind of what they're getting into. But I find with urinary diversions, as long I'll give the information in bits and pieces, and then a lot of times a lot more of the information will come when they're ready, and they'll call other patients, or sometimes I'll have another meeting with them. But you're right, I don't like to give it all at once, all the information, because I find sometimes that people walk away remembering nothing. It's just too much.
Mhm.
So that's absolutely true. Okay, so question about for patients, this is a couple questions about non-muscle invasive bladder cancer. So I'll go ahead and answer some of those. For non-muscle invasive bladder cancer treated with BCG, is there a time frame when recurrence is most common? Does the likelihood of recurrence decrease the longer you go without recurrence? This is a question in general about surveillance. It's true of muscle invasive disease and non-muscle invasive disease. And the answer is that the vast majority of recurrences for non-muscle invasive bladder cancer occur within the first year, and certainly within the first 2 years. Within the first year, you would expect 80% of recurrences to happen. Within the first 2 years, you would expect 90, or some people would even say 95%. After 2 years, you would call something a late relapse. And there's a school of thought that I actually subscribe to that believes that if you have a recurrence after 2 years, it should be thought of as a second, almost like a second primary bladder cancer, sort of like a new bladder cancer, and you should treat it like that. Similarly, for people who have disease that's outside of their bladder, in the lymph nodes and beyond, certainly the rate of relapse, goes down at 1 year and certainly 2 years. But I always tell my patients, this is a marathon. It's not a sprint. Bladder cancer is a marathon. It's not a sprint. And just to get in that mindset. Okay. The effect, there's a question about radiation and sort of the effects of radiation, cystitis, and leading to bleeding and clots. And is there any treatment that can prevent recurring bleeding? So this gets into sort of some of the side effects of not doing surgery. So chemotherapy and radiation or trimodality therapy is one route. Webb didn't take that route for various reasons, but it can be an option in certain cases with muscle invasive bladder cancer, but it also comes with side effects, such as radiation cystitis and what's called hemorrhagic cystitis, which is a form of radiation cystitis where you bleed a lot. There are some treatments. It's a tough complication. It's a tough side effect. There's been some work looking at hyperbaric oxygen, and there's been some work looking at some other things, but it's once again something that is it can be difficult to treat. There's a couple more questions here. I want to make sure I get to everybody's. Are there studies looking at diet and lifestyle changes on recurrence? And this is a question both for non-muscle invasive and all of bladder cancer. Yes, there's been a lot of studies. However, none of those studies have turned out something that is definitive. I will tell you, I think exercise and a diet that is low in sodium and high in fruits and vegetables is a good thing, but that's not based on level 1 data. That's based off of me putting different pieces of data together. So I always recommend that, but I wouldn't say that we have any definitive data. And that's partly because these studies are incredibly difficult to do. If you think about it, when you do a study of 1,000 people and you split them into 2 camps, 500 and 500, you give one group one drug and one group another, it's pretty easy to figure out if one of the drugs is working better. But if you split those people into 500 and 500, and then you ask one group to do certain types of exercises and another group not to, there are so many what's called confounding variables. There are so many things that people will do. Well, the group that's not doing that exercise, maybe, they're not reporting it, but they're getting up and they're, doing CrossFit twice a week. Who knows? Like, there's just so many things that you can't control when it comes to lifestyle changes that it's incredibly difficult to do an appropriate and good study around that. So it's a really complicated issue. It doesn't mean that there aren't lifestyle and diet things that can impact your cancer, but it just means that it's a really hard thing to know definitively. Okay, so some more questions. This is a patient who is dealing with a complication from radical cystectomy, namely frequent urinary tract infections. This patient has an ileal conduit, but patients with neobladders also can have frequent urinary tract infections. This is an issue for patients, and each person is different. We need to make sure it's not a problem with the kidneys, that there's not a blockage of urine getting freely down to the ileal conduit or the neobladder. What's the best way to sample the urine? I always tell people your urine is going to grow out organisms if you have a urinary system that's made of intestines. So it doesn't really matter. There's not a perfect way. Putting a red rubber catheter in the ileal conduit is probably the best way. But at the end of the day, it's going to grow out something. And so putting a lot of good heads together, sometimes infectious disease needs to get involved. Sometimes, there needs to be more imaging done to try to prevent these frequent urinary tract infections, which are a tough issue after surgery. There's a question of, is it possible to know if tumors are recurrences or new primary tumors? It's a really good question. You could think about doing genomic sequencing on a recurrent tumor and seeing if it's different from the primary, but we're not there yet, because where you choose to take what the piece of tissue you choose, and then within the piece of tissue, the microscopic piece that you choose to sequence might make more of an impact than whether it was the recurrence or the primary tumor, meaning within the same tumor, the sequencing might be different. That's called tumor heterogeneity. And so we're not really at a point where we can know if something's recurrent or primary. I'm not sure it matters too much. Within 2 years, if you have a recurrence, we think of the biology of the disease as being resistant to whatever treatment we're giving, and usually we'll try to switch treatments. But it's a great question. Really good questions here. There's a question about the GI microbiome, and are there studies looking at the influence of the microbiome on urinary diversions? Yes, those studies are ongoing. Certainly, they're at their nascency, and nothing really that I would report. This last question, after BCG, does recurrent UTIs indicate that the cancer will come back? No. Recurrent UTIs can be a marker of what's called carcinoma in situ, or CIS. So it's always something, I'm thinking about, but usually recurrent UTIs are not an indication that the cancer has come back. Yeah, so there's one more question I'll just answer about BCG. We're still in a BCG shortage. My belief is that once you're cancer free at 2 years with maintenance BCG, you no longer need to be on BCG, and so I do not recommend going back on BCG if you haven't had a recurrence. It's usually, it's usually absolutely fine just to have surveillance cystoscopies. Okay, there are more questions here, continuing to be about non-muscle invasive bladder cancer, which is fine. There's a question here about blue light cystoscopy. So when do we use blue light cystoscopy? So I use blue light cystoscopy for the diagnosis of non-muscle invasive bladder cancer, particularly when somebody has a history of carcinoma in situ or CIS, in which it's not really obvious whether they have a recurrence or not. And I want something to enhance my visualization of the bladder. And that's when most urologists will take that, will use that. All right, these are great questions. This has been a great discussion. I'm going to go ahead and just end this a little early. I think we've had a really good discussion. And if questions come up, once again, please don't hesitate to email bladdercancer@jhmi.edu. And if you want to, participate in a more active role in the GBCI, if you want to just start getting the newsletter, please go on our website. But I kind of want to turn it back and say to Mr. Metz, thank you again for your willingness to share, for your willingness to speak. It takes a lot of courage. And it's really important. I think that there's a lot of people who were listening into you today that gain strength from hearing your story. And whether they say that or not, I know it to be true. So I appreciate you, and thank you all for attending this session, and have a great day.